Welcome back to Econ 3875, Health Economics. In this module, we will be discussing the role of government in the market for medical care. When economists look at government involvement in markets, we often ask why. And there are generally two reasons why we believe that the government may choose to step in. First is the public interest theory. This theory suggests that the government steps in to improve the lives of its citizenry by correcting for inequities and other problems that can occur in a market-based system. The second theory is much more cynical and suggests that legislation is determined solely by special interests of the voters or the legislators. Note that these theories aren't mutually exclusive, so the truth may lie somewhere in between. However, we must realize that governments may not be able to correct efficiently for market failures, and in fact, government policy may actually create more problems than it solves. We must remember that governments and markets are both imperfect and fallible. There are several different ways in which the government can intervene in markets. The government can provide public goods that private markets may fail to produce, but consumers want. It will levy taxes, sometimes solely as a revenue source, but also as a way to alter consumers' behavior. This occurs when it uses a tax, for example, to correct for an externality, which we will discuss more in a moment. The government may also regulate businesses and try to control monopoly power. And of course, the government also produces some goods and services, so it does operate public enterprises. Last, the government redistributes income and wealth across households. Some of this is to correct for the inequities that a market economy creates. Other redistribution can occur from the young to the old, say in the form of Social Security or even Medicare. As mentioned a moment ago, the government can use taxes or subsidies to discourage or encourage the consumption of a particular good or service. This often occurs when the good causes an externality, which is a benefit or cost that is borne by a third party. Here's an example. Suppose we're thinking about cigarettes. There are two parties involved in the sale of cigarettes, the buyer, or the consumer, and the producer. But secondhand smoke causes a third party, anyone nearby, to be impacted by the consumption of the cigarette. In this case, there is a cost forced upon the third party, but that third party has no say in whether the cigarettes get produced or consumed. So there is an external cost. What does the government do in this case? It taxes the sale of tobacco. Some of that tax is used to reduce the incentive to smoke or to decrease the quantity of cigarettes demanded. We can make similar arguments for alcohol taxes where the externality is drunk driving or perhaps family issues, and gas taxes where the externality would be wear and tear on the roads, pollution, and traffic congestion. Keep in mind that there can also be positive externalities. If you live in an apartment building and you purchase a fire extinguisher, your neighbors benefit even though they don't have any say into that decision. By that argument, perhaps it would be efficient for the government to subsidize the sale of fire extinguishers to encourage their purchase. But since the externality only exists in apartments and not homes, that's not very feasible. So, take another example, flu vaccines. When you receive a flu vaccine, that not only benefits you, but it benefits those who are around you. My guess is when you decide to get that shot, you're not really thinking about the benefits received by others. Because the government knows that this benefit exists, county health departments often provide this vaccine for free. The government is also interested in ensuring competition in markets. Therefore, we have a system of antitrust laws that regulate the market power of any one firm. However, the government does allow mergers and acquisitions if cost savings are significant. This is why we are seeing more and more large firms in medical care. Also keep in mind that the antitrust legislation in the U.S. only has control over U.S.-based firms. Therefore, mergers and acquisitions that may take place in other countries are out of the U.S. realm. Even if they might make the markets less competitive, the U.S. government doesn't have really any say. The government may also produce some goods and services, including health clinics. These clinics are generally underfunded and are becoming more and more rare. These organizations often see patients who are more ill on average. And of course, probably the largest government producer of medical care occurs through the Veterans Administration. The redistribution function of the government comes from the fact that a market economy is generally believed to be unfair and results in an unequal share of goods and services across individuals. To the extent that society cares about equity, our government has several programs that lend a helping hand to those who need it. Of course, the funds for this come from other households who have more. We must remember, though, that there is a trade-off between equity and efficiency. Guaranteeing someone an income lowers the incentive to work hard and save. And we know the system's not perfect, as it is virtually impossible to detect who actually needs assistance and who might be taking advantage of the system. The government also acts as a health insurance provider for certain segments of our society, including the elderly, the disabled, and the poor. As a producer of health insurance, the government collects taxes and premiums and then bears the financial risk of providing insurance. It must also create a system to reimburse providers, so they have to decide how they're going to pay physicians and hospitals to cover the medical expenses of those who are insured. Let's start with the Medicaid program, which provides health insurance to the poor. This is a program that is actually jointly funded by federal and state governments, but it is purely administered by states. Each state sets up its own eligibility standards and level of benefits, but there is a minimum level required by the federal government. This means that Medicaid benefits can vary greatly from state to state. You might also recall from an earlier lecture that the ACA attempted to loosen the Medicaid eligibility standards across states, but this provision was actually declared unconstitutional by the Supreme Court. Table 10.1 here shows you how the number of recipients and dollars paid out in Medicaid have grown over the past 40 years. The numbers on these PowerPoint slides have been updated from those in your text. For example, in 2016, over $361 billion was spent providing health care through Medicaid. A more recent initiative to improve the health of children has been the State Children's Health Insurance Program, otherwise known as CHIP, which was created in 1987. This provides health care for children of low-income households without health insurance. In the last unit, we saw a figure that showed how health insurance coverage varied by age. CHIP is one of the reasons why children have a lower rate of being uninsured than even working adults. Now let's move to Medicare. Medicare is a federally funded and administered program that provides health insurance coverage to the elderly and the disabled. Anyone over the age of 65 is eligible to receive Medicare, regardless of their work history. Individuals under age 65 who have been determined to be severely disabled may also be eligible for coverage. There are 4 parts to the Medicare program. Part A is hospital insurance. This is the part that every 65-year-old is automatically eligible for. Part B is called supplemental insurance. This covers doctor visits and other outpatient procedures. This requires individuals to pay a monthly premium to receive coverage. The premium, though, is not the full cost of the insurance, so the insurance is subsidized by taxes. Part C is the Medicare Advantage program, which is a managed care plan that combines Parts A and B in an HMO type of program. It is voluntary, but it does require a premium to be paid. The latest change to the Medicare system occurred in 2003. This is Medicare Part D, which is the prescription benefit program. Before 2003, Medicare had no coverage for prescription drugs. Most seniors had to purchase a private supplemental plan if they wanted insurance coverage for their prescriptions. This next slide shows you how Medicare is funded. Notice that Part A, the hospital insurance, is not funded by premiums at all. In fact, it is mainly funded through a payroll tax. You see this on your paycheck every pay period. Part B is funded in part by premiums paid by those covered, but more of the cost is actually funded by the general tax revenue from the federal budget. The same is true for Part D. This next figure shows you how Medicare spends its funding. Medicare Advantage is the managed care version of Medicare, and as you see, the number of patients enrolled in it and its cost increased a lot as a proportion from 2006 to 2016. Just like we've seen managed care grow in the private sector, the number of patients choosing managed care under Medicare is also growing. To control costs, the Medicare program has undergone a variety of changes over time. In 1983, the government altered the way in which it reimbursed hospitals from a fee-for-service basis to something known as a diagnostic related group, or DRG. The DRG is a prospective payment system, which means that hospitals are basically only promised a fixed dollar amount per patient given a particular diagnosis, and the hospital must make do with that amount. This shifts some of the risk from the government to hospitals and is meant to encourage less waste and more efficient provision of services. In 1989, the government made physician reimbursements fixed as well, based on something known as resource-based relative value system. This payment is valued at an estimate of the resources used by the physician to treat a particular patient for a particular diagnosis, and that includes the physician's own time. There are also strict limits within Medicare on the amount a physician can charge, especially when it comes to something called balance billing. Physicians can't just say, well, we'll take what Medicare gives us and then we'll shift the rest of the cost to the patient. It doesn't work that way. As I said earlier, in 2003, the federal government added a prescription drug benefit to its coverage. The federal plan is optional, and seniors still have the option of purchasing a private plan to cover drugs. But the federal plan is subsidized, so for most, it is a cheaper option. But the coverage isn't quite as wide and far covering. The diagram here shows you how Part D worked in 2017. Keep in mind that there are several plans for a person to choose from, so these numbers have to be calculated for any particular year. And it's pretty convoluted. Basically, for the first $400 in drug expenses, the patient would have to pay 100%. This is because there is a $400 deductible. Then, for the next $3,700 in drug expenses, the patient would pay a 25% coinsurance rate, and the government would pick up the remaining 75%. However, after that $3,700 has been reached, the patient now has to pay an even higher coinsurance rate, up until the patient hits a yearly maximum of $8,650 out of pocket. During this time period, or during this level between $3,700 and $8,650, the patient would pay 50% of any name brand drug and 44% of any generic. Once the $8,650 is hit, the patient would then only have to pay 5% of the drug's cost. Sounds a little crazy, huh? The higher rate of coinsurance from $3,700 to $8,650 is often called the donut hole of coverage, because basically in that range it's like having little or no coverage. Let me also say that I took this chart from a website that sells additional insurance to senior citizens who are covered by Medicare. These additional plans are often referred to as Medigap plans. The plan references in the chart, especially in the blue area, refer to the additional insurance policy, not the Medicare insurance. What I really wanted you to see are the numbers in the second column. So we started out this module talking about why the government might get involved with markets. The last thing I want to mention to you is some concern that individuals may have about the intervention of government. For one, we might want to go back to questioning the why again. What exactly are the incentives of policymakers? Are they really trying to improve societal welfare, or do they have other interests? Is it political? It is difficult to look at our political process these days and believe that legislators always have society's best interests at heart all of the time. We also might want to be concerned about unintended consequences of government policies. Why do unintended consequences occur? Remember that when you change policies, you are basically changing the rules of a game. And of course, when you change the rules of a game, you change the way in which players may play. And we don't always look forward in trying to see how individuals will react to policy changes. Policymakers really need to look at prospective policies and try their best to determine how individuals are going to react. This will help prevent unforeseen effects from well-intentioned policies. In this unit, I'm going to ask you to watch a piece by John Stossel about unintended consequences. And then I have for you a discussion question that I think will be a lot of fun. I'm going to ask you to develop a potential health policy. And then in your responses to your classmates, I would like you to suggest potential unintended consequences that may occur as a result of those policies. Try to do this part early because it's more fun the sooner people post their policies and the more people can think about what could possibly go wrong.